I've got 2:30. This is the Pediatric Subcommittee meeting. We're calling to order August 21st at 2:30 p.m. So, first order of business is roll call. I'm Charles Macias, I'm chair. Deb Brown, I know, is not going to be with us today. She sent her reports. Britt DeVillier. Here. Bonnie Hartstein. I know she was here earlier.
Yeah, she was planning on being here.
Charles Jaquith. Here. Juan Juarez. Here. Julie Lewis, I know, will not be here, and she did forward her reports as well. Jorge Sainz.
Here.
Sally Snow.
Here.
And Vern Walker.
Here.
Great. Thank you, guys. All right, so we start, as always, with our committee liaison reports. First one is Air Medical. Jorge?
They'll meet tomorrow. So, like I did last time, I just kind of send you the report.
Okay.
Haven't met yet.
EMS, Vern?
Also meets tomorrow, and there were no specific pediatric issues in the last meeting that they had.
Okay, education, Charles?
They met this morning, just before us, had a very short meeting lasting less than 15 minutes.
That's efficient.
And no pediatrics were discussed at that meeting.
Pediatric issues. Okay. Injury prevention. That is Deb's, so we'll look for a report on that.
They meet tomorrow too.
Meet tomorrow. Medical directors, Juan Juarez.
They will meet tomorrow also.
Do you remember any specific pediatric issues in the last meeting?
On the 15th of May, there were no specific pediatric.
And stroke. And that is Julie's. Trauma systems, Sally.
Trauma Systems meets tomorrow afternoon, and I will be attending that meeting and will submit a report for inclusion with the minutes.
Okay. Regional, the RACs. Britt?
They meet this evening.
Okay, and I have your report from last time in the minutes. And disaster planning, that's Bonnie. Okay. And I think her specific report was no specific pediatric issues we addressed last time. All right, so next agenda item. Oh, there she is. Just in time. We were just talking about the disaster planning liaison report.
Okay, so I went to the meeting this morning, and there are two relevant topics to bring up. Give me a moment to look at my notes. One was the discussion of the NICU ambuses, and I had the opportunity. They didn't go into a whole lot of detail at the actual meeting, but I did have the opportunity to talk to Eric Epley afterward, and he said that they were working on making sure that the older style isolates that could fit onto and be secured on the buses, because the newer ones were lighter weight and they were able to be secured on the platforms. But they were working on that and had some success with at least going to Christus Santa Rosa in San Antonio and making sure that they could secure down the smaller ones.
So are there any specific standards that other states have described, or?
He didn't mention other states. He said that the NICU transport teams generally use a smaller, more portable, lightweight product. But then if they expected to have to just go out at large and pick up neonates in other places, right, they may not have this kind of more state-of-the-art equipment. And could they then load? What would be the barriers to moving children in that regard? So that was one issue. And they are also, just to summarize, they kind of had a moment where they looked back to see what had been done and looking forward to what the future would hold for the disaster management team, and had talked about maybe having a one-day kind of bull session where they just really planned for the future and said what the next 3 to 5 or even longer years with Holden, he kind of invited a pediatric representative to that, saying that that would be beneficial.
Oh, that's wonderful.
Were they talking about isolates or baby pots?
I think isolettes, that was my, but you know what, maybe I'm misspeaking. It was what the neonatal transport teams were using at Christus Santa Rosa and San Antonio, so maybe you may be more familiar than I.
We actually use both.
Okay.
You know, so the baby pot is something that looks like, for lack of a better term, like the Spock, you know, from Star Trek, you know, device, you know, save them out.
Okay.
And it's very portable, it's fairly inexpensive, you know, it really doesn't have a lot of warming capabilities or anything like that, but you can transfer on neonate very safely, very easy access. The isolates are very heavy, you know, has a ventilator, all this other infrastructure, so, you know, I would think that probably, if they're thinking about securing them, it's probably the isolates, because they're much more difficult to secure than the baby ones.
I think that's what they were talking about, the older style or even the bigger isolates. And then-
Yeah, use the microphones.
Can you not hear me?
Mm-mm.
I don't know.
More than AW.
Hello. So the discussion surrounded what type of neonatal transport product we were talking about, and I think that what they were talking about were the older style isolates, if you can hear me, and he was talking also about getting getting the air refilled as necessary, and working on that, you know, the oxygen, etc. So some more on that, but the good thing is that they are investigating it and working towards it. It is a goal, and I think having a seat at the table as they kind of draft the plans for the next several years would be helpful.
Okay, and that you are that designated person?
I mean, I
As
can
the
be.
liaison?
I mean, or I can send out the email when I find out when it's coming and see if anyone else wants to
Well, I
join
mean,
in.
I think it's appropriate as our
Absolutely,
liaison.
I'd be happy to. Yeah, that was my plan.
And they were talking about the end of September, 1st of October, somewhere
Right,
around in there, as
sometime
soon as they
around
set a
that
date.
time frame. And I'm on that distro list, so I'll, you know, find out what it is and let you know tomorrow.
Perfect, thank you. All right, so that concludes our liaison reports. Next is our EMS for Children State Partnership update. Sam Vance and Dr. Manish Shah. So Manish, we have some significant discussion interwoven with the National Readiness Project with our piece. So I don't know what order you were going to present your work with, but if we could do that one last.
Do that one last?
Yeah.
Sure. Last out of my section, or
Out of your
do
section.
it later?
Out of
Okay.
your section.
Sure. Then I'll have Sam go first and talk about the assessment, and then I'll talk about the other two things.
Hello, I'm Sam Vance. I'm the EMS for Children Program Manager. I just wanted to give you all a reminder about the EMS reassessment that's coming up in October. Many of you may remember back in 2010, nationwide there was an assessment done of all the ambulance services and first responder organizations across the country to determine if they have the proper equipment and online and offline medical control. So in 2013, they're doing a reassessment to see if we are doing any better, any worse, or have stayed the same. The nationwide, the first cohort started just a couple of months ago. Our cohort starts in October. And because we have so many different departments across the state, they allow us to do a sample survey. So we are sampling is of 480 different departments across the state. I have made contact with a good portion of those. A lot of them I have not. However, if there are any RAC chairs or RAC directors in the room, I would greatly appreciate your help in contacting them. I have broken down those departments by RAC and have those lists with me. If anybody's here right now, I'd be more than happy to give those to you when we're all done. Okay, great. I'll also be at the RAC chairs meeting this evening, and you'll hear me say the same thing again. So, like I said, if you could help me out in contacting those folks, I would greatly appreciate it.
So, a question.
Yes.
That's
Oh, okay, I'm sorry.
So my question is, we have done this in the past with this assessment.
Right.
I contacted every single person that you had on the list, and we had a pretty good response.
Right.
Are you wanting us to redo that again, or are you using the data that's already been submitted? I mean, it's been a while.
Right, that was the assessment done in 2010. And this is a reassessment, and I will tell you that the list, so how that is done, we give all of the department names to the National EMSC Data Resource Center in Salt Lake City,
Right.
Utah, and they put them all in the computer, and the computer spits out the names.
Right. Because that
A
was
lot
the
of-
problem, a lot of them were inactive.
Right, and I have tried to go through and clean up that list of the sample. I'm not going to tell you it's perfect, because there's probably still a couple, 2 or 3 of them, if not more,
No,
out
that's
there that
okay.
are not.
I just want to clarify if we were revisiting the same group or if it's a new sample, so it's a new sample.
There are going to be some on there that were in the initial assessment in 2010, but a good portion of them are new.
Okay, thank you.
And like I said, I've been able to make contact with quite a few of them, but it does include the first responder organizations, so the volunteer fire departments. And as y'all know, they're not always there. So those are the ones that I've had difficulty in making contact with. And I don't know if you all have any better means of doing that than I do or not, but if you do, I would appreciate the help.
Sam, two parts to a question. The first one is the sampling window you said begins in October. It ends when?
It begins in October. The portal closes, I believe, at the end.
January 8th.
January 8th. Thank
Okay.
you. Yes, because Sally was taking notes yesterday.
So then the second part of the question is, can we revisit this in November and have this group help as well?
Yes.
With contacts that linger beyond that date.
Yes, that would be greatly appreciated. And just to kind of expand on that a little, I will be sending out letters and emails to these departments about the middle of September, a pre-notification letter to let them know that they're going to be a part of the survey. And then at the end of September, I'll be sending out the letter and the email to the departments to let them know that the actual survey, which is online, begins the 1st of October. And as y'all can imagine, we do have the holidays of Thanksgiving, Christmas, New Year's in our survey time. So that kind of creates a little bit of a challenge for us. We have asked NEDART for a 3-week extension, but have not gotten an answer on that yet. So hopefully at the next meeting, we'll have an answer for that. So, are there any other questions?
And just to add on to that, Sam, we also tentatively plan to try to have some computers set up in the exhibit hall at the EMS conference, so if people want to go ahead and do their assessment there, they can do it then.
Yes, thank you. And also along those same lines, if folks do not have computer access, we will have paper copies of the survey available. So, all righty. Then I'll turn it over to Dr. Schmidt.
One of the other things that we wanted to provide an update on was on guideline development. So in the past, we've shared with this group as well as the medical directors and the EMS committee about a pediatric protocol resource tool that's available on our state partnership website. In addition, I wanted to let the committee know that there's a national movement through the National Association of State EMS Officials to create model clinical EMS guidelines for approximately 40 common conditions for both adults and children. And I'm one of the American Academy of Pediatrics representatives for that committee. And so there will be drafts of those guidelines that will be available for public comment in the spring of 2014, and we're hoping to finalize those guidelines by September of 2014, and this is a project that's funded by National Highway Traffic Safety Administration, and this grant has been given to NHTSA. It's led by Rich Kamen and Carol Cunningham. They're the state medical directors of Connecticut and Ohio. So more to come on that.
Is that simply development, or is that development, uptake, dissemination, and uptake?
It's uptake and dissemination. I just want to clarify that these aren't intended to be evidence-based guidelines that go through the model evidence-based guideline pre-hospital process that's been developed by the Federal Interagency Council on EMS. They're intended to be consensus-based guidelines to be used voluntarily by medical directors for their EMS agency. It's meant to provide a minimum standard or minimum guidance for common practice with references and considerations that that should be thought about when implementing. However, any guidelines that are in existence that have gone through the model pre-hospital evidence-based guideline process, which include air medical transport, pain management, seizures, and pediatric respiratory distress, those will be implemented into the resource as they are and just adapted into the format. And then to another mention related to guideline development is I've received funding to create 4 new guidelines. So I've mentioned before about our pediatric respiratory distress guideline that we've implemented in Houston, Dallas, and Austin. We have funding to create 4 new guidelines on shock, spinal immobilization, allergic reactions, and airway management. These will be created over the course of the next year, implemented in Houston as a pilot, and then they'll be implemented in all 6 New England states with outcomes assessment using NEMSIS data. So I wanted to provide an update on that as well. And once those are created, those will be available on our state partnership website as well. And then the last thing I was going to cover was the emergency department readiness. So we've mentioned in the past that there is a National Pediatric Readiness Project. This is a quality improvement initiative to assess the pediatric readiness of emergency departments across the country. It's based on guidelines for care in the emergency department, which was a document published in 2009. And we were one of the first states to participate in the assessment on a nationwide level. We collected our data from we attempted to collect data from every emergency department that's open 24/7 in the state of Texas that has, even if it's freestanding, as long as they have an affiliation with an inpatient service at another hospital. So this did not include minor emergency centers that don't admit patients. So the national assessment is ongoing, and by participating, the participating hospitals received immediate feedback so that they could be compared to other hospitals of similar type, of similar volume across the country that had finished the assessment up until the point that the person at the hospital completed their assessment here in Texas. And so the assessment gathered information on a variety of things, and I'm going to give you just a brief high-level view of our Texas data with the intention that we're going to break this information down on a more regional level and distribute them to the RAC chairs and collaborate with emergency departments in various regions of the state to lead to more quality improvement on a regional level. The domains assessed in the assessment are noted here. There's 6 of them. Each of them had a point value that's noted in parentheses to give a total score of out of 100. We attempted to assess all the emergency departments. As I mentioned, there were 504 emergency departments in Texas that are open 24/7 that meet the criteria that I mentioned, and we had a response rate of 60%, so we have data from 305 emergency departments. Our overall state score out of 100 was 71. The national score is right next to that, 70. So we're about similar to where the nation stood at that point when the assessment our assessment closed at the end of March. Like I mentioned, the assessment is ongoing, and so now there's more data, and so you can get real-time data. You can view real-time data on the National Pediatric Readiness website. Most of the emergency departments in our state are general EDs that are not freestanding EDs, or they don't have a separate pediatric emergency department, or they're not in a freestanding children's hospital, as one would assume. And so that represents most of who responded to our questions. I think that this slide is relevant to the EMS world. We asked, at what age do you have a cutoff for pediatric medical conditions in your emergency department and pediatric trauma conditions in your emergency department? So at what age do you consider it a cutoff? to make a distinction between a child and an adult. And so what you see here shows that most emergency departments have a cutoff around 17 or 18 for both medicine and trauma. And I think this has implications for EMS because we've been asked before as a state partnership to provide a definition of what pediatrics is. And to have a meaningful definition, I think it's also important to know, well, what's the definition that the hospital uses? Because we can make up a number, but if the hospital uses a different definition, then that may lead to secondary transfer to another facility if the patient requires inpatient treatment.
Yeah, one thing to add, about 2 years ago, we had discussion over setting a definition that we offered to Big GTAC, and within that definition, it was not just hospital-based, but also disease-based, because the importance of understanding the difference in anatomy and physiology was important. So we crafted that caveat there as well.
Right.
So I just wanted to clarify.
This slide shows the inpatient services that admit children. So the hospitals were asked, if you admit children, to where in your hospital can you admit them? And so many hospitals don't have a separate pediatric unit, but can admit children to an adult unit. And then you'll see that there are NICUs in 28% of the hospitals and PICUs in about 9% of the hospitals. This also has implications for EMS, because if you are transporting a patient that is critically ill and needs an intensive care unit, and knowing what are those facilities in your region is useful information. Also, it's important to know whether a hospital has inpatient capabilities to admit children at all, because if a patient clearly has a condition that is going to require admission, then transporting them to the right place where they can be admitted would avoid secondary transfer. Further definition of that on a regional level would be important in collaboration with both EMS agencies and the local hospitals, which I'll mention in a minute. What you'll see, this is a breakdown of just state scores compared to the national scores, and you'll see that as the pediatric volume of the emergency department increases, their scores in terms of pediatric readiness increase. And so that highlights that potential areas of need to address are those hospitals that see less children. And so that's something that we hope to do moving forward as we break down this information on a more regional level. This assessed whether the hospital has a coordinator, either a nurse or a physician, that has somehow in their job the responsibility of being a coordinator for pediatric care. That didn't necessarily have to be their entire job, but it had to be a component of their job, and there were questions that asked whether that was if there was a job description for that, and if there were a list of responsibilities for them. And Texas scores were slightly above the national scores for that. On subsequent slides, I've noted in red, since there's a lot of numbers on the next few slides, I've noted in red areas where the response was less than 70%, where people didn't have that one thing that we asked about, and in green if it was more than 70% of the time available in the emergency department. So for these, it was less than 70%, but our scores were slightly above the national in terms of availability of a nurse or physician coordinator who oversaw pediatric care. In terms of competency evaluations for nurses and physicians, they're commonly there for nurses but not physicians. In terms of who are the providers that care for children in the emergency departments, as one would expect, most of them are emergency medicine physicians. Surprisingly, there are far more family medicine physicians than I had expected, and as one would expect, there are very few pediatric emergency medicine physicians and pediatricians, since the majority of children who are cared for in the emergency departments across the country are cared for in general EDs rather than children's hospitals. And then there are a variety of other physicians that staff the emergency departments that are noted here on the side that comprise less than 1% of the physicians. We also asked questions about what are the training requirements for those that care for children in the emergency departments, and this question for physicians was asked strictly for the people who are not board certified or board eligible in emergency medicine by either ABEM or AOBEM. or pediatric emergency medicine physicians. So for those that were family physicians or anesthesiologists or surgeons, does the hospital require that those physicians take things like ACLS or PALS or ATLS? And so about 60 to 70% of them do require PALS, ACLS, and ATLS for those physicians. And you'll notice that for nurses, it's even more common to take courses like that. It's more in the 90 to 95%, 90 to 100% range. For mid-level practitioners, like nurse practitioners and physician assistants, it's not very common. So one thing we also assessed was quality improvement and process improvement, whether the hospital had a process improvement plan in place or a review process for specific cases. And so overall, that was present less than half of the time, but for those that did, there were things in place to look at patient outcomes, to develop a plan for improvement based on those cases. But overall, like I said, it was there less than half of the time. And so this, I think, is also an opportunity, since we're here at GTAC, this is relevant to EMS because one of the things that was mentioned in the Institute of Medicine report in 2007 on the emergency care for children was that EMS agencies should have some sort of coordinator for pediatric care, and that person should be a liaison with their local hospitals to help coordinate care. And so this is an opportunity where a designated person in an EMS agency could work with a designated person in an emergency department to help with things such as case review, to make sure that the hospital and the EMS agency are in agreement over the care that's being provided in the pre-hospital setting, that they're aware of the guidelines or the protocols that are being used, so that the physicians in the emergency department know what they can and can't give in the pre-hospital setting, and to make sure that there's consistency there. And then to also give feedback, both good and for improvement for providers as well. And so having that communication along the continuum of emergency care is essential. There are other things that we assessed related to vital sign assessment and weighing patients. And one thing that we noted was that patients are not very frequently weighed in kilograms. This has safety implications since medication dosing for pediatrics is based on kilograms, not pounds. And so this is an opportunity for improvement at the hospital level. And then we asked other things as well in terms of guidelines and policies and procedures on a variety of things that I've noted here. I won't go into that much detail on that. And then finally on equipment, we assessed a variety of equipment that a consensus panel believes should be present in any emergency department to care for children. Overwhelmingly, more than 90% of the hospital emergency departments in Texas have all of the pieces of equipment. There were some areas where they were available less than 70% of the time, and those are noted here. Umbilical vein catheters, central lines of the 4 to 7 French size, tracheostomy tubes of the 3 and 3.5 size, and then laryngeal mask airways of the 1 to 2.5 size. Certain things were available 70 to 79% of the time. Of note, a 0-0 laryngoscope, which is useful in the setting of a premature infant delivery. And then certain things were available 80 to 90% of the time, such as waveform capnography, pediatric McGill's, non-rebreather mask, and nasal cannulas for infants. But like I said, the majority of the equipment was available more than 90% of the time. And so some of these things, I think that there is an alternative that could potentially be utilized if it were absent. Such as a tracheostomy tube. If you're in a pinch, you could cut an endotracheal tube to at least put something in the airway until something more permanent could be swapped out. But certain things are gold standards, such as waveform capnography to confirm intubation, or they're essential for premature infant delivery, like straight blade 0-0 tube. If you have an infant delivery, you need to intubate that premature infant. So I think there's opportunity for targeted improvement in areas where these things may be commonly missing. However, I will say that laryngeal mask airways are more commonly available in Texas compared to the nation. However, these things that I listed on the right are less commonly available compared to the national numbers. So where do we go from here? Like I mentioned, we're going to compile aggregated reports on a regional level. one of the things I want to ensure that people understand is that when people filled out these assessments at the emergency department level, they were ensured that their individual hospital's responses would be confidential. So if we have a response from a region, if we have less than 5 hospitals in that region, we can't share that information because we have to have at least 5 hospitals in a given region in order to share aggregated data on them. But if we have at least 5 hospitals in a region, which we do for most or all the regions, then we can give each region a summary of their own data so that at a regional level, people can decide how they want to use this information to collaborate with their local emergency departments to help improve care along the continuum. In addition, I'll be sharing this information with the Texas College of Emergency Physicians Board next month so that we can come up with strategies of how to improve this at a hospital-wide level. And then our hope is that we can develop regional plans for improvement with stakeholders, many of whom are here in the room and present at GTAC. Any questions?
Go ahead. Yeah, the Texas overall response rate was about 60%.
Yes.
Is that, in the numbers that you're projecting from Texas, is 60% really reflective of Texas as a whole? For example, California had about a 90% response rate. Numbers of respondents were about the same. So they were, I think, 300 out of 335 or something like that.
Mm-hmm.
We were 305 out of 500.
Uh-huh.
One, can we improve our response rates in the future and get a more comprehensive look at what actually is happening in Texas? And at what level response rates, let's say we were 50%, would we want to extrapolate that data to Texas as a whole if we only got a 50% or 60% response rate?
Sure, that's a good question. So Texas has the most emergency departments of any state in the country. We assess the most number of emergency departments in the country compared to any other state or territory. So although California did have a 80 to 90% response rate, we still assess more hospitals than they did because they have less hospitals. So many states did achieve a response rate of greater than 90%, but some of these states, for example, Delaware has 8 emergency departments. So in order to have generalizable data, usually when you do an assessment, having a greater than 60% response is considered good. Considering if you have a greater than 80% response rate, I think that's great. And so to put it in perspective, like when we did our EMS assessment back in 2010, we had an 84% response rate of those we sampled. We sampled half. In this situation, we tried to get in touch with every single emergency department. So the fact that we got 60% of all emergency departments in the state, I think, is very representative of the state. However, when you break it down on a regional level, that may not be true. However, I would say that these scores are we also compare these scores in comparison to other similar hospitals across the country. And I think seeing that Texas data is very similar to the nation also tells me that it's valid information. It's valid data.
Well, it's calculable, right? It's the greater the number of agencies and hospitals, the smaller the confidence intervals are around the expected rate. So even though we're 60% with such a large number, 50%, 80% in a place with 10 has wider a broader sensitivity, right? So.
Yeah, and in terms of your other question, in terms of are there ways to improve this in the future, I will say that personal contact is the most effective means. 3 weeks before our window of assessment closed, we were at a 30% response, and then we mobilized resources to have people get on the phone and actually call these hospitals. We do a 5-phase contact method when we do assessments, both for EMS and for the hospitals. That includes verifying contact information, multiple levels of email and mail contact, and then finally with personal contact over the phone. And so the personal contact over the phone is the most effective. It's also the most time intensive. And so, however, we did jump from a 30% response to a 60% response over the span of 3 weeks when we had 3 people making phone calls for us. And that's how California did it as well. California had 6 paid people to make those phone calls for them. And so that's one effective way to do that. And so that's the approach that we take when we do the EMS assessment as well. We send out notification in advance. We update contact information to try to make sure it's as accurate as possible. We send out emails. We send out actual paper letters. We give people multiple alternatives to fill out the assessment, whether it be online if they can do it. That's preferred. If they can't do it online, then we send them a paper one. I had some people fax back a handwritten one, and we manually entered it in. And then as a last effort, we start making phone calls.
One question. What do you think is the top reason why people were not responding?
A variety of reasons. We received feedback from some hospitals that they were told that by hospital administration that they shouldn't fill it out. I think that comes from misconceptions about what this is. Some hospitals thought that their individual hospital data would be used against them in some way, which is not true since we can't release individual hospital data. The only people that get their own data are their own hospital. And so we tried to clarify a lot of those things. We spoke to people over the phone to clarify those misconceptions. We directed people to the National Pediatric website, Pediatric Readiness website, which clearly explains what the project is and how it's to be used. But sometimes it's an issue of time. There aren't personnel in the emergency department.
That's my biggest concern.
Sometimes
they
it's
did
that.
not respond. Because they don't have the resources yet. We're making a generalization for the state. It's like building up a road that is perfectly drivable, but it still has holes on it. You know what I mean? So I guess the question behind that is that at the end of the day, do you think that overall all of the regions were well represented? Yes.
Yeah, so we do see that most of the regions were represented, and we had a variety of responses from hospitals that were considered low volume, medium volume, and high volume. So we did have the whole spectrum of types of hospitals, both by region and by pediatric ED volume, represented in our sample. In terms of respondents, yes.
I'd just like to ask you a question about something you said prior to this presentation, and it was regarding the consensus-based guidelines you're working on with the AAP. And are those pre-hospital?
Yes, they're pre-hospital guidelines. The efforts led by the National Association of State EMS Officials. So these are pre-hospital guidelines. The majority of the people on the work group are state medical directors. Represented on the committee are Utah, Maine, Connecticut, Ohio, Pennsylvania. In terms of state medical directors, I might have missed a few. And then they were intentional about identifying representatives from certain organizations to make sure that there was representation. And from a pediatric perspective, every single guideline is going to be looked at from a pediatric perspective as well, to make sure that even chest pain is going to be looked at and even stroke, so that if there are certain considerations that need to be made for children, those are integrated in. And so we have a panel of seven of us that are pediatric emergency medicine physicians from across the country who are splitting up the task of reviewing all the guidelines to give pediatric feedback on all of them.
And they'll be published on the NAAP website or the...
They'll be published on the NASEMSA website, okay. And then there are also discussions about publication in a journal as well, potentially pre-hospital emergency care.
Thanks. I'm particularly interested in if there's any disaster type protocols for the future. So maybe I can get your contact information.
Sure, and I can send you the full list if you'd like. I can send it to Charles so you can disseminate it to the committee. I don't believe there's a specific one for disaster. We had a long discussion over what should be included and what shouldn't for this first go around. So we came to agreement on a list of initial 40 guidelines approximately. I don't believe that was on the list, but this is a first step, and I'm sure that NHTSA plans to add others in the future.
Did you define the regions that are going to distribute this information? Is it via the RACs or is it
Yeah, so we're in the process of compiling the data on a regional level, so we don't have that ready yet for the RACs, but we'd like to give that to the RAC chairs. In addition, I'm going to meet with the TSET board next month and work with them to come up with a way that we can distribute this to on a regional level as well. And so that's still yet to be defined how to do that, but that's our intention, because most of this, I think, needs to be addressed at the hospital level. But I wanted to highlight a few things here because I think that there are implications when it comes to EMS working with their local hospitals.
So one of the discussions we had at our last meeting was centered around utilization of this information. How do we really translate this into significant uptake that directs best practices and changes outcomes for patients, which is in the end what you want any bit of data to do. And so we broke up the domains and assigned elements of the different domains to different committee members. And so I've got a couple of reports for people that are absent, and since this is an ongoing project, I don't think, in the interest of time, that we need to address all of those components today. So why don't we do a couple per each session, and if you wouldn't mind just sort of creating a framework for us of critical issues amongst these different domains. So the first domain for the National Readiness Project was administration and coordination.
Sure. I'll pull up the slide again to bring up the broad overview of the data.
And so the charge that Deb Brown, in her absence, volunteered for was that she would describe best practice strategies for addressing this domain. And so I have a report in front of me, so I thought if you could first define the topic for us, and then I'll describe her report.
So you said administration and coordination?
Administration and coordination as the domain.
Okay, so that's this one. This is the one that looked at do the hospitals have some sort of personnel, a nurse or physician, who oversees the responsibility of pediatric emergency care as part of their job. And so the importance here from an EMS perspective, I think, is making sure that EMS agencies can work with an identified person at the local hospital in their area to help coordinate care.
Okay. So in her description of best practices, Deb submitted the following: that opportunities for exposure for expanding the ED physicians' awareness across all emergency departments, not just in pediatric EDs, was more robust rotations of adult ED physicians and pediatric EDs. She gives the example of some of the largest EDMD groups in Central Texas. Bonnie, you're probably better equipped to answer this question, but with regard to ABEM-directed programs, or not directed, but higher affiliation of adult EM programs, what is the requirement for adult ED trainees for rotating for their pediatric experience?
Oh, the number of months or the amount, the scope?
The number of months, and what is the scope?
I don't know that I can quote the ACGME right off the top of my head. It has expanded. I know that the requirements are increased recently. In the last, I think, 2 years, they increased the rotations. I know that I think in our residency, they're doing several, they're doing a PICU and an emergent pediatric inpatient and in some, so I wouldn't be able to quote it off the top of my head, but there are, I think, up to 4 to 6 months of pediatric exposure in a 3-year residency.
Okay.
With a minimum, I think with an absolute minimum of 2. So which still, the argument that we always pose, when we talk to the adult folks as far as, bringing the residents into our ICU is, to us, is always too little.
Too little.
But I think that they have a caveat, and please don't quote me, but pretty sure they have a caveat with a minimum of 2 months, which, the ACME would allow you to have a, workable program, if you only provide that.
Also, I think there's an implication here, in terms of EMS training, not just pediatric training, but EMS training. Emergency medicine residents, as required by ABEM, have to have an EMS rotation as part of their residency. The American Board of Pediatrics does not require a specific EMS rotation for pediatric emergency medicine physicians. It just states that it needs to be integrated into their fellowship somehow. So it could be part of an adult emergency medicine rotation, but there are no guidelines about whether it's 2 weeks or 4 weeks, if it's separate or not. And so what I have found is that many pediatric emergency medicine physicians have a lower understanding of how EMS works compared to emergency medicine physicians. And so I think that's also an opportunity to educate pediatric emergency medicine physicians about how EMS works, what is scope of practice, how does medical oversight work. There are many opportunities for improvement from that perspective as well.
So, and that's good. So I think and I'll summarize each of these points as I take the minutes, but I think the point that she makes is that we could broaden the exposure, and I'll add in the link to the pre-hospital education to really enhance recognition of pediatric-specific issues and trainees. Ultimately, what we wanted to do with this is to offer you a list of what we view as important points to improving best practices, so these could be posted or somehow integrated with the state partnership so that when hospitals are wanting to respond with best QI practices, they're tangible things with links to places that have them. And so
Sure.
we'll be providing that.
So I would say the number one thing, though, is that each hospital emergency department designate a person, whether it doesn't have to be a nurse, doesn't have to be a physician, just a person who is a liaison for pre-hospital agencies in their region.
Right. The charge with this, though, was really to look at other best practice strategies that are not just locked into those domains, because those are fairly simple.
Sure.
So the other suggestion she had was looking at CME requirements. Hospitals have required adult ED physicians to attain a certain number of PDCME hours per year as part of their credentialing processes. Is it possible to expand scope and direct some of the curriculum within the hospital-based credentialing? Mm-hmm. Third one was involvement in PIQI initiatives related in pediatric care, and that was just about standardization. Is there some opportunity to provide programming related to with pediatric cases in the adult world? Patient safety initiatives, specifically high reliability organization methods, bringing that out to the community, and I think some of that will be built into the QI components. Partnerships with pediatric organizations in region or systems to address pediatric care needs, and participation specifically. She talked about ED RN roles, what pediatric experiences could or could not look like, expanding credentialing for more nursing exposure to pediatric-based training, policy development, partnering with pediatric facilities to expand policies, protocols, and guidelines. And then the last one she offered was involvement of PIQI initiatives related to pediatric nursing care, more shared dissemination knowledge of policies and procedures across the state. Our personal experience is even within our own institution, we can have 5 different policies related to entitled CO2 use. So I think her points are well taken, and we'll forward all of this. The second report was by Julie, and this was looking at the domain of quality improvement in the ED. And she actually provided resources from the American Academy of Pediatrics on evidence-based guidelines and evidence-based resources. She provided some written literature in up-to-date on pediatric safety and QI, some HRQ links, some links on the EMSC IPEMS, and hospitals and health networks, and I think these will provide some nice links for the website as well. So we've got 40 minutes left. So I think we can take at least another report. Let's see.
Mine.
Sally, you want to do equipment, supplies, and medications best strategies?
Okay, I was going to talk about transfer guidelines, but I'll talk about
Okay.
supplies and medications. But that's easy because there are standards set out there. I mean, there are the guidelines for care of children, then the emergency department has a list of the medications that each emergency department should have, equipment lists the same way, and for pre-hospital providers, there is a brand new list of equipment that's coming out that's been approved and is about to be published but has not yet been published. So I think there are all kinds of standards and best practices out there for us to just look at and try to get people to accept, which we've done in the past with some success.
Okay, do you want to talk about the transfer code?
Yeah, I was asked to look at, and I brought to Dr. Macias a recommendation that we try to begin some discussion about having a transfer guideline for the state of Texas, which is very specific about what patients should be transferred. And one of the examples that I looked at to try to come up with some template for that is the Washington State Pediatric Consultation and Transfer Guidelines for Trauma and Critical Illness. And they kind of break their transfer guidelines down or the need for transfer by 3 levels. So they look at kids that need critical care, those that need to be transferred for a higher level of care because the place where they are can't meet their medical or nursing care needs, and then those kids that can be safely cared for in the hospitals that they're in. And their criteria for transfers very specifically broken out for trauma patients using physiologic criteria like neurological status, respiratory distress and failure, if they're intubated, if they're in shock, if they're requiring blood to maintain vital signs, if they have head injuries, specifically open fractures, depressed fractures, if they have penetrating injuries, pelvic fractures, things like that. Then they go to anatomic criteria and burn criteria based on the ABA criteria, and then they have other criteria that specifically says if they need ICU care or they might benefit from consultation. And then their non-trauma transfer guidelines, very similar with physiologic criteria that talk about very much the same thing, other things like arterial pressure monitoring, CVP, pulmonary artery pressure monitoring, do they need ICP monitors, vasoactive medications, are they in hepatic failure, renal failure, hypo or hypothermic, and things like that. And then other criteria like near drowning, status epilepticus, dangerous envenomation, life-threatening ingestions, and things like that. And then they have a section in their guideline that talks about transport teams and transport methods. And they specifically talk about the method of transport, the equipment that's necessary, the kind of communication that is necessary on those transport teams. And then they break down their personnel by specifically things like it says stable with no risk for deterioration. They say that child can be transported by an EMT that has the capability of giving oxygen, monitoring vital signs, saline locks, and things like that. And then they go all the way up to the patient that is unstable, and they say that requires a paramedic with a pediatric transport team being highly encouraged. So they prescribe very clearly which patients should be transported by what level of personnel. Then they talk about they list the designated trauma centers and burn centers in their state. They have an actual template for interfacility transfer checklist, and then obviously the references for all of the things that they used in their guideline. And when I looked at what Texas requires that hospitals have a policy on transferring patients, but it does not require a transfer agreement. A memorandum of understanding can be in place as long as you follow EMTALA, essentially, is all it says. And I think everybody in this room knows that they have to follow EMTALA and that they have to have a policy. Many hospitals, especially designated trauma centers, have a transfer agreement. But what we don't have in the state of Texas is a statewide transfer guideline. Some RACs have transfer guidelines for pediatrics. I know Deb and Lori and I wrote one for Trauma Service Area E years ago, but I don't think all RACs have transfer guidelines, and it would be a really good idea for us to make a commitment to develop a statewide transfer guideline that was very specific like the Washington State one.
Thanks, Sally. So I think if I'm understanding this correctly, within the domain of equipment, supplies, and medications, one of your proposal for the best practices to say if you can't meet those and you can't provide the services, then this is a best practice
Yes.
to understand when to transfer. Was there any, Manish, was there any reference in the, are you aware of any reference specifically to transfer guidelines in the questionnaire itself?
Yes, and I apologize. I didn't put that data into these slides. That relates to EMSC Performance Measure 76 and 7. Since we were already going to contact the hospitals to ask all of these questions, we also asked the questions about do they have interfacility transfer guidelines, and we asked, like we did last time, about each of the 8 components that are recommended on a national level by the EMS for Children program, and then also do they have transfer agreements in place. When I looked at the data for Texas, it didn't differ much from when we did our 2010 assessment. I'd say many of the hospitals have guidelines, very few have agreements. Out of this, the 8 components that are recommended on a national level, the state of Texas in Texas Administrative Code, I think it's in 157, mentions 6 of the 8, and so more than 90% of the hospitals actually have 6 of those components in there already because it's mentioned in rule, but the other 2 are not.
And Charles, the AAP has on the section of transport medicine, a booklet on pediatric transport guidelines that has some emphasis of what we're talking about today, and they're about to come up with a new edition, the 2013. So there's already 2 previous editions to that.
So it sounds like, at least in terms of providing resources, it sounds to me like what you're saying is that many hospitals already have components in place, but not necessarily any standardization for physiologic criteria, et cetera, for transfer, correct?
Right. Many of them have like an unspoken agreement with hospitals in their region, but they don't have it in writing. And many of the hospitals, in whatever internal guidelines they have when they transfer a patient, have the majority of the essential components in them, but not all the ones that are recommended on a national level, but they have the majority of them. But in terms of what Sally's mentioning, I think that there are implications, looking back to when I had the slide about which hospitals have an inpatient unit that can take care of kids, which ones have a NICU, which ones have a PICU. Right. I think that there are implications beyond trauma for interfacility transfer guidelines and agreements, and because many hospitals don't know what the inpatient capability of other hospitals in their area are. They may know that the Children's Hospital has a PICU and a NICU and an inpatient floor, but they may not know that the closer hospital down the street actually has an inpatient pediatric unit, and they could transfer them there and save the more critically ill patient bed for the one at the Children's Hospital. So I think that looking at it from a statewide level to identify what are the capabilities of each hospital and mapping it out would be very helpful. And this is something that we've talked about at a state partnership program level.
I think that's great. And I think, to Sally's point, I think that such a transfer agreement policy, template that creates guidelines for both trauma and non-trauma would give us a framework to understanding what exactly would such a matrix need to look like that would inform others in the absence of this capability with this patient. What are your options? Mm-hmm. So this sounds like pretty much the project that we took on with radiation, CTs and radiation. So I think we can put that on the parking lot and bring that up in the meeting that follows our November meeting, our February meeting. So I'll just put a placeholder for that, and then I think in the meantime it would be helpful for people to see the Washington State guideline and the transport criteria that the AAP has as hospitals are coming back to these resources to look at QI improvement.
And I would also remind people in the audience that there is an pediatric interfacility transfer guideline toolkit that you can link to from the pediatricreadiness.org website. It's one of the 4 blocks down underneath the 5-year-old scenario that was developed by the Society of Trauma Nurses, the Emergency Nurses Association, and the EMSC National Resource Center. That is just an amazing resource for everything you would ever want to know about how to develop a pediatric interfacility transfer guideline. The Washington State guidelines are there. There are templates of guidelines that are transfer agreements that you can develop. There are state regulations. There's an amazing amount of resources there, so please remember that that's there.
All right, so that leaves us with 3 other domains related to the National Readiness Project that we'll take on in our next meeting, which is patient safety policy, and that is Vern's, policies, procedures, and protocols, which is Juan's, and ED support services, which is Jorge's. Is that okay with you guys?
Just a point of clarification, the transfer policy and guideline creation, that fell under my domain, and so do you not want me to address that?
Oh, I think that from your perspective of the crossover of policies and procedures, it would be helpful. Do you want to do that now?
No,
Crossover to
I'll
transfers?
do it next. I'll tie it in.
Okay.
And Charles, I do have an answer for you. It was, I just looked it up. It was 5 months of pediatric experience, 5 FTE months, and if you have an ED, you take the percentage of pediatric patients multiplied by the time of how many months you spend in your regular emergency medicine rotation, you get a total of FTE months, and then you have to also supplement that with just pure pediatric rotations, and it also has to include pediatric critical care experience. So that's kind of the way that it looks like.
So that's helpful in understanding what baseline is. Okay, thank you. One other thing related to the EMSC State Partnership Report, I think, although I know this wasn't on the agenda, but one of the components or one of the strategies or one of the domains of looking at the way knowledge is translated in research to uptake and uptake to acceleration of everyday use through evidence-based guidelines, and then evaluation of those outcomes is related to what new innovation is put out there. And so when we look at what has been described in the pediatric pre-hospital world, there's some evidence that has been described in testing, and it's great that NHTSA is going after standardized protocols and giving us opportunities to understand how to accelerate uptake of new information. But one of the gaps we've always faced in the pediatric pre-hospital world is that there hasn't been a lot of funding or infrastructure for research in pre-hospital, pediatrics in the pre-hospital world. And Manish was just part of a, and if I could just put you on the spot, Manish, if you could just give us a one-liner of this new EMSC-funded initiative to expand research in the pre-hospital world and your engagement with that.
So the EMS for Children program issued a funding opportunity announcement back in the late winter to fund 6 different grants, and one of them specifically was earmarked to create a pre-hospital research node of 3 sites that needed to be in different states. And so the award was funded to Medical College of Wisconsin to create the CHAMP node, and CHAMP stands for Charlotte, North Carolina, Houston, Texas, and Milwaukee. So, sorry, I meant Milwaukee, not Madison. So those 3 cities, Charlotte, Houston, and Milwaukee, are going to collaborate to identify potential areas that can be researched when it comes from a pediatric pre-hospital perspective to do multi-center research. And that's in collaboration with the Pediatric Emergency Care Applied Research Network.
So to my knowledge, and please correct me if I'm wrong, this is the first federally funded initiative to create infrastructure for researching issues in pediatric pre-hospital care?
Correct.
I think that's remarkable. Congratulations on that. All right, next on the agenda is an update on Child Fatality Review Team. Susan Rodriguez sends her apologies. She is ill. However, she did have a report prepared for us, and she's provided some websites for us, which we'll post in the minutes so that you can have the URL links. But under Senate Bill 66, she wanted us to know that they've added 2 new members to the state's child fatality review team. This is an EMS position and a family violence service provider advocate. Calls for nominations will go out September 1st of 2013, and new members will be elected at the October 18th state CFRT meeting. She had suggested that this might be in the works, so it was great to see that memorialized. She also noted that the annual child fatality review report would now become biannual, and that under Senate Bill 66, they would create a 15-member Protect Our Kids Commission, specifically to study child abuse and neglect fatalities, and that DFPS would be the agency supporting that commission. Their first report is due on December 1st of 2015, so to give you an idea of the kind of work they'll be doing. Identify promising practices and evidence-based strategies to address and reduce child abuse and neglect fatalities, to develop recommendations and identify resources necessary to reduce fatalities, develop guidelines for the types of information that should be tracked to improve interventions and to prevent fatalities from child abuse and neglect. She also noted that under that same Senate Bill 66, that there would be a release of the DSHS Texas Health Steps online provider education module on recognizing, reporting, and preventing child abuse. That's available free with that link as well. She also wanted us to know that the Senate Concurrent Resolution 1 provided for April as Water Safety Month in Texas, at least for the next 10 years, and that there would be a planned water safety summit for later in the fall to bring together water safety coalitions, Safe Kids chapters, Parks and Wildlife, Army Corps of Engineers, RAC representatives, DFPS, Red Cross, and others to share in water safety efforts. She noted the CFRT prevention activities include Safe Kids Texas Heat Stroke Task Force, water safety media events in Houston and San Antonio on April 1st to be called April Pools Day. Interesting. Infant Safe Sleep Promotion, and then Infant Mortality Collaborative Improvement and Innovation Network, which is a separate report description. 14 state work groups on 5 different areas of focus: smoking cessation in pregnant women, elective delivery, interconception care, perinatal regionalization, and infant safe sleep. And then she gave us some resources, URL links, which also will be posted, describing the standardized provision of safe sleep education and training for providers. So that is the CFRT report. She intends to be here at our next meeting. That moves us to our position paper on minimizing radiation. As you'll remember, we had talked about translating this information, this paper, into something tangible and something that could inform specific activities. So we broke up the domains of that position paper into several segments, and we have a number of reports here. So we'll get through as many as we can so that we can address the remainder of our reports. And the first one is all CT scans on children should be performed using pediatric dose reduction protocols. Pediatric protocols are available through the Alliance for Radiation Safety and Pediatric Imaging, and that champion was Vern.
Charles, as I began to look at this, I became confused in what my charge was. So if I could table mine and bring it back next time, then we'll.
So table to next meeting. So it was really looking at what best practices were out there, what hospitals are using, how we're disseminating knowledge about dose reduction protocols.
So about how to disseminate that knowledge out, and figure out what those barriers are.
Are there any states that have taken active initiatives to within their hospitals to populate these dose reduction protocols? Is there anything that's mandated versus anything that is set as education versus just sort of passive information uptake?
Okay.
So just what best practices are out there? So let's move to Britt. You had a couple of these. Are you ready for your reports, or do you want to table those? Okay. So avoidance of the use of protocols which automatically result in the performance of multiple CT studies: head, cervical spine, chest, and abdomen, and pelvis.
My understanding was the process of how to implement or distribute this information. And my first thought was actually to look at who is doing the protocols, who is ordering the imaging, So my thought was to how to best reach the physicians or the primary care providers that are ordering these studies. Since this committee just has the charge of an advisory role, and the first step might have already been done because I missed quite a bit last year, but to be sure that GTAC, the formal committee GTAC, has approved and acknowledged our position paper along with the Trauma Systems Committee, and then forward that position paper to both TCEP to distribute to their group as a possible resolution to be presented both at the state level and the national level, then also to present to the Committee on Pediatric Emergency Medicine of the AAP or the local Texas Pediatric Society Committee on Pediatric Emergency Medicine. Our radiology group discussed this with them on a one-to-one level, and on a nationwide pediatric radiology society level, they have already begun implementing these processes within the pediatric institutions. It is the general institutions that we need to achieve or reach these goals with. So my thought was if we can get the backup, the resolutions through the national organizations such as ACEP and AAP, then we would definitely have a step in the right direction. The third step would be to have trauma systems pass this information as a recommendation to the ACS to begin implementing these guidelines as possible criteria for trauma designation. Again, it's the general facilities that a lot of this is targeting, as the pediatric facilities are already instituting these processes, and to get that information out, even though it would technically be a guideline and a recommendation and a suggestion to the ACS, not necessarily a requirement at this time, but to be able to get this information, again, distributed to reach all of these avenues, I think would be a success.
Okay, thank you. We did, and you are correct, at one of the meetings you missed, we updated the status with GTAC, and although there was lots of discussion over what could be endorsed and what the role of GTAC was in endorsing, they did agree to essentially back or endorse this position paper. So your suggestions are great, so we can move right to those. All right, you also had a second agenda item, which was imaging modalities that do not use ionizing radiation, such as ultrasound, should be used when feasible.
I believe I just combined all that.
Okay. Jorge, you had understanding and linking guidelines of care that utilize evidence-based practice strategies will help minimize the use of unnecessary testing.
Yes. So in my mind, there's two particular important issues to attend, for that particular point. The first one is to, it was to look at the group of individuals making the right decision to do the right test at the right time, but making sure that test resolves what is going to be available for other, to see. So we discussed this in the past as far as, trying to make a recommendation to be able, especially with technology now, to have the ability to read those studies and to have, I'll give you an example, you have a referral physician, referral institution that undergoes for a CT scan, and then, they might or might not have individual protocols, which is something that is going to be addressed differently. And then they refer the patient to you, and you have to repeat all those tests because those tests are not available. So hopefully in the future we could make a recommendation at the accreditation possibly process, for the trauma systems, and eventually from there disseminate it to the rest of the hospitals that are even non-trauma related, as be able to participate into these programs, to be able to make sure that once that test has been done, that test is available to be reviewed, hopefully even before that patient arrives to your institution. The second task that I found actually extremely challenging is the development of specific algorithms when to actually radiate an individual. Say, for example, they come into the pediatric ER, and then you're going to have to make a decision when to obtain a CT scan versus not. And when I talk to our pediatric radiology folks, there's definitely different hospitals throughout the states that actually have developed specific algorithms. Texas Children's might be one, Cincinnati Children's probably is another one, but they're not sharing those specific algorithms, on the internet. So I really couldn't find any specifics, and how to, I know that they exist, they belong to the institutions, but on what I was told that even on the previous, state meeting for pediatric radiology, that that they discussed that matter, and they're still reluctant to make those algorithms available to everybody else. Does that make sense?
It does.
Yeah. So the first one would be to recommending to make sure that even though the appropriate tests are done, but they're actually readily available for everybody else to see. And the second one is an algorithm for making the decision process when to radiate somebody appropriately.
Okay. And I did receive your report, and so when I post these minutes, we'll have all of the links that you've included in there as well.
And to answer one of the other questions that you said before, I only found when I was doing all this and the Image Gently website that only the state of Minnesota has actually endorsed it. But there is actually been the first state, at least on the Image Gently, website, that has endorsed it as a recommendation. They probably have very little power to enforce it, but they are endorsing the website.
Okay. And Juan, we have. Did you want to report your two independently or together?
Together.
Okay.
I think what I was charged with was addressing the avoidance of repeating imaging after the initiation of a transfer to another facility for patients to minimize.
We can't hear you. Sorry.
Oh, sorry. I was charged with looking at the avoidance of further CT after the initiation of a transfer from one facility to a receiving facility. This issue has, I think, 4 parts to it. One is an education issue to understand the ionizing radiation effects on children. There's better data now in recent kind of long-sustaining data that will point to how many cases of cancers or body masses that are essentially linked to certain dose of radiation. Not everyone is tuned into this information, and so I think partnering with not only ACEP but hospitalist medicine groups as well throughout the state to inform them on the effects of radiation on children at specific ages would dramatically improve some of the algorithms that are already in place. Secondly, would be to create a system-wide algorithm that would be in part with the transfer facility algorithm that we were talking about earlier, that could recommend when we would repeat CTs. And I believe most of that in the literature and with established algorithms have said that if it was medically necessary, and that's going to be the gray zone for most receiving facilities to define medically necessary versus the utilization of other modalities like ultrasound and things like that.
So correct me if I'm wrong, but I think most of this literature, and you point out very well that there's some gray area with what's medical necessity, but it seems like most of the literature points to most of the repeat CTs being done in trauma settings for transfer from one patient to another, where it's not about medical necessity but about actual data transfer.
Correct. And so that would get to the second point, and I'll come back to that. Okay. The third one would be the enforcement of an established algorithm, and that's going to be our limitation in whatever process that is established with the algorithm. The actual enforcement of that has to be not only with it's a unified effort, both from radiology, from a cost-effectiveness basis, and looking at the long-term costs that we are incurring of repeating CAT scans, as well as from the emergency department and its resources. So we'll have to establish teams that will look at the entire transport, interfacility transfer process, as well as labs / ionizing radiation to enforce the algorithm in place, and then ultimately to follow up. I think there's a specific disconnect once the patient is out of the ER. Is there any follow-up to the direct clinical provider of diet of the CTs that were ordered and whether that was medically necessary or not. So a quality initiative process has to be established as well. So most places that are tertiary care centers have similar processes already established. And so that's where most of these patients are coming from, but there's non-standardization. And so really what I'm talking about is having those 4 processes support a standard. Now, to further alleviate that, the last charge was should we avoid repeating the scans and consider it a cloud-based digital technology. So that's an ever-evolving process of which there are multiple vendors out there that do provide this service. So it is a local hospital issue on whether to provide the service. Typically, when a tertiary care service, a hospital purchases one of these cloud-based technologies, they are allowed certain licenses that provide free cloud-based service to from its referring hospitals. So the cost is minimum to those. It's usually incurred to that primary hospital, of which, because there's such an intimate link with all these secondary hospitals, they're more than willing to incur that cost. So the utilization of that may actually supersede the first charge, which is which would make the repetition of CAT scans if the problem is due to just not having the read, not having the CD, not having the image in front of you. The cloud-based technology should alleviate that.
Okay, so I'll assemble these in a more presentable working document so that we can just sort of offer some bullet points for how we could improve those strategies.
And I will send you the links that I have this evening.
And Charles, I really believe that cloud-based technology, at least in our region, not only will save money, but it will save lives.
Absolutely.
And which is a very important point, because what that allows you is to have your team set up in place before the patient arrives to your hospital, which, based on our resources, at least in our region, sometimes is not the case. Give you a perfect example. Right now, if we get a patient coming into us, we scan them, then we call neurosurgery. If you have that test available, you'll be calling the neurosurgeons, and the neurosurgeons will assess them before they actually get there.
Right.
So
I think there's certainly a lot that could inform this, and some great examples, and I think it'll be worthwhile putting some specific examples in the document as we craft this. So we've got 7 minutes and 50 seconds left, and so I'm going to address our last 2 points very quickly. The first one I'm going to call on Jane in a second here, and that is that was discussion of Senate Bill 8 regarding laws and policies related to the licensure of non-emergency EMS transportation providers. I received a series of emails from different members that we're probably not privy to the entire discussion, because the segments that we looked at didn't put it into contextual understanding of what the history of this discussion was. Would you mind just giving us a 2 or 3 one-liner about what led up to this particular discussion and why this became an issue?
Yes. Actually, with this legislative session, Senate Bill 8 is almost a companion to House Bill 3556. Both of the bills are targeting providers trying to address issues related to fraud and abuse of the Medicaid system. And SB 8 has several requirements that the department has to meet. And one of these is that we have to provide the legislature a report by January 1 of 2014 with recommendations. It talks about getting stakeholder input and providing recommendations back to the legislature on potential laws or revisions to law targeting the transport providers.
Okay. And what kind of time frame are we talking about for feedback?
The feedback has to come back through the council in the November meeting.
Okay.
So any recommendations that you have that come from your committee, any feedback that suggestions that come out of your committee, will have to go through the GTAC Council by November, and that's it. Then it comes to me. I literally have about a week, 7 days to turn it around and get the report out of our office.
So there was an email that Dudley had circulated proposing that the EMS committee take the lead on this. Is that what pretty much is happening? It seemed from most of the discussion that not discussion, but the emails that were sent to me to discuss during this meeting, is it didn't seem particularly pediatric specific.
Right, it is not pediatric specific, but we want anyone who wants to have a voice or make suggestions to have that opportunity. And Dudley did offer to take the lead on this, to have the EMS committee take the lead on it, and I think Chief Riley said, "Thank you very much, you're it." So
we felt comfortable with that too.
Right, I think most people were. So I believe Dudley's plan is to have a road show and travel around to different locations in the state in September and October, and then have suggestions ready to go back to the council in November that the council can then discuss and make recommendations to the department.
Perfect. Well, then we will bring this back up, and please, in the context that we've now heard, please forward your comments. I can assemble them and we can discuss them at our November meeting.
Still just section 9 and 14 as the primary?
Yeah, I think that was still.
Yes, that's correct.
Okay.
And there was a document that, there was a work group from 2002, I think, that looked at this issue, and that was one of the it's not actually, I think it's termed minutes actually from this Transportation Task Force. That was one of the documents that was provided just to give a starting point. Okay.
We'll redistribute those. Okay, we talked about transfer guidelines, trauma registry. Jorge, you've got 2 minutes and 15 seconds.
Oh, yeah. Well, actually, I'm glad that Jane is sitting there because, please correct me, Jane, if there's any other things that we need to update the team. But the most important thing is that it was dictated that, that we're going to have a pilot study for the trauma register that actually started, in June, and, we're going to be reviewing, what had been the pitfalls and the questions and how to improve that pilot study. That's actually RACD. Who volunteered for the pilot project. So tomorrow we're actually going to be discussing that on a 2-hour meeting. I don't know, Jane, if you want to mention anything else. I actually missed the last couple of phone calls, over these, so I don't know if any other details you want to fill in that.
Well, we did have the first meeting at RACD, and it was the trauma program manager and the project manager for the new registry. That was Tammy Sajak and Rob Klein, and myself and Emily Parsons and Colin Crocker. We all went to RACD, and it was a general meeting at RACD. And we talked about the registry and what the barriers to both EMS and hospitals. It was a joint meeting of EMS and hospital providers, what the barriers were for them inputting information into the registry. So I thought it was a very good exchange. There were about 50 individuals there, and I don't know how many actual providers that represented. And the next thing that's going to happen is the registry staff is actually going to do some one-on-one training with hospitals and some of the EMS providers to help them get up to speed so that they can actually input information into the registry. There was it was a good give and take. There was a lot of it really just pointed out that there's ongoing training that needs to be done. It's very different than the old registry. There were some good points that came out. Even though we thought we did a good job of looking at our old data elements and the new data elements, one example is that for patient disposition, there's death and there's expired. Both of those selections are in the registry. So it was like, well, we didn't realize that. That was just one of those things that we didn't realize. So I'm not.
Colin, do you know when is it? We have a date set for them next for the registry staff to go up?
No, late fall we're going to follow up. Actually, the trauma registry folks are going to be down there in the next 45 to 60 days to work with stakeholders in RAC-D. And then later on in the fall, we plan to have at least one kind of final meeting to wrap things up down in RAC-D and go over actual findings again and make sure all problems were addressed.
Okay, great. So our time is up. I think that concludes our meeting. Thank you.
Hey.
See, you didn't believe it.
Yeah.